Thank you to the organizer of Pharma for having me here to present a novel yet practical approach to evaluate benefit and risk of medical products using Bayesian methodology. My name is Sarabh Mukhopadhyay. I am a research fellow at Statistical Innovations Group at AbbVie. The benefit risk assessment the benefit risk assessment of or BRA that we call it usually is a key element throughout the life cycle of any medical product. The idea is to show that its benefits surpass its risks. So it's a very simple concept, but the challenge comes from conducting a rigorous and evidence-based BRA, and that the challenge comes because it involves making transparent and entirely measurable assessment. So the approach that we proposed here is a novel approach where we achieve this transparency and measurability in a few steps. The first, it measures the preference of a treatment for a specific disease or indications. It does so by conducting a specially designed stakeholders preference or trade-off survey and estimate the relative preference parameters, which we call beta sometimes for our purpose. And we estimate that using a hierarchical Bayesian model. We call it HBBR, which is abbreviation for hierarchical Bayesian benefit risk model. Second is to obtain the performance of the treatment for that indication. So there are basically two components. One is the preference component that we estimate through the stakeholders preference survey, especially designed survey that we'll talk a little bit about. And other is the performance of a treatment for which we are trying to measure the benefit risk assessment of. And then that part, the performance part of the treatment is obtained by the results from a clinical trial for that treatment, and the concerning parameters for performance, we indicate that by nu. So these betas and nus are the two components that we mix to come up with the overall benefit risk score that you can see here on the left. And it is actually coming from an utility theory, which is discussed in details in our 2019 paper. But the key idea is that we have the preferences, we have the performances, we combine them in a very simple way and to come up with the overall utility. And that utility, we will show that how it can be used in order to measure the benefit risk assessment or the preference. If we want to compare two treatments, we have BRA for both treatments, or maybe two different doses of the same treatment, and we can compare them. So those things are done in a very rigorous manner, and everything is measurable. The key challenge, of course, is how to get these preference parameters. This part is measuring the performances are relatively easy because it comes directly from the clinical trial, but this one requires a stakeholder survey, and that is one of the key contributions of our proposed method. So let us talk about a quick illustration on where we consider a benefit risk value tree to start with for a hematologic indication. And here we want to estimate the preference parameters, which we are calling betas. The benefit risk value tree consists of two component benefit attributes and risk attributes. For benefits for this indication, we identified three key attributes: overall survival, response rates, and quality of life. And for risk, we identified hematologic toxicity and infections. And here you see that for each within each attribute, we can have different levels, and that's what the betas are, how betas are estimated. And what we do in this survey is through asking some choice questions, responders make a trade-off to see that which one they would prefer in terms of a combination of benefit and risk. So that's what we achieved through a specially designed discrete choice experiment. And this involves comparing only one benefit and one risk attributes at a time to reduce cognitive burden. And we also use only the non-obvious questions or non-obvious choices, which we call non-dominant. And that way we reduce the total number of questions we need to ask to the responders. And then we employ the theory of random utility in order to come up with the overall estimate through HBBR model. I'm not going to get into the details on that, but again, I refer to the paper to discuss where we discuss that in details. And so the key idea here is that we need only a very few number of responders, and each responders need to only answer a very few questions. And that is what we have achieved through this hierarchical-based model. And that way we can employ it, we can use this kind of survey even with a few responders, whether it is the patients or some experts in the field. Only a few responders can fill out the survey, and we can get a very good idea of the preference parameters on those attributes. So once we have those attributes, here is an example of how only 30 odd responders had responded, and we estimated the preference parameters for each of the 5 attributes. Naturally, we would see a positive values for the benefit attributes, and the risk attributes will get negative values based on the model settings. And then we also use a mock data here to come up with the clinical trial data for which we want to from which we want to estimate the ETAs or U parameters. And these new parameters and beta parameters are then combined with their uncertainties, and that gives us the benefit risk utility score that we have I've come up with using the random utility theory that I mentioned before. So finally, I wanted to say that once we have this utility score, we can actually compare different doses of a treatment or different treatments. And on the utility score metrics, we can use that. Or we can also convert that in a preference matrix, and that is where we can get more clarity. Here you can see that some of them are overlapping almost entirely here, but if we convert them in preference probability, then there is a clear dissonance between these 2 treatments. So with that rapid description, I have just one more slide here to talk about the hypothetical treatment profile. Sometimes you don't have even and treatment from a clinical results from clinical trials. You can even assume some of the results, and you can still see how the treatment will look like in real world if that's what you actually get out of that clinical trial. So that's another utility of this method. So finally, I have a software, Sine-based software that I plan to launch sometime. It is getting ready, and hopefully RN Pharma will give the platform to have it launched there. And I would like to also acknowledge that this methodology and our Sine applications resulted from an ongoing discussion with the benefit risk subteam of the Bayesian Scientific Working Group. And this view and the opinion presented are those of mine, and not to be attributed to the organizer I'm associated with. Thank you very much for your attention. I think I am 1 minute over time, but if there are questions, I can follow up later.